We're going to talk about fever in the pediatric patient. Fever is one of the most common reasons for pediatric office visits and telephone calls. Fever is the physiologic rise in the hypothalamic set point in response to endogenously produced pyrogens. What causes fever? Infections, malignancies, autoimmune diseases, metabolic diseases, chronic inflammatory conditions, medications can cause fever, CNS abnormalities, and heat exposure. Most fevers in pediatrics are caused by self-limiting viral infections. Teething does not cause fever. And fever leads to increases in the heart rate of 10 to 15 beats per minute and an increase in the respiratory rate of 3 to 5 respirations per minute for each elevation of degree of centigrade. The child presenting with fever. What do you want to obtain in your history when you are evaluating a child who presents with fever? First of all, you want to know the duration of the fever. How many days have they had a fever? And the degree of fever. And remember to ask the parents when the fever started and then count. If the fever started on a Thursday evening, then to Friday evening is 1 day. To Saturday evening is 2 days, and to Sunday evening is to 3 days. How did they measure the fever? Sometimes they just say that the child felt warm. That is still important for us to know. A tactile temperature is something that we should still consider as a fever. We want to know if they administered any antipyretics and the timing of that. And I usually want to know what they gave, what the dose was, how they administered it, and how long ago the child received it. You want to know what any associated symptoms are. Parents become so nervous when their child presents with a fever that they stay very focused on the fever and on the number. And sometimes we have to stop them, especially on the phone, to ask them what other symptoms does the child have. And then you want to ask specific concerns, such as, does he have a cough? Does he have a sore throat? Is he pulling at his ears, or does he seem to have an earache? Does he have a stomach ache? Does it hurt when he pees? So you have to ask direct questions in addition to beginning with an open-ended question, such as, what other symptoms does he have? But I don't end with that. I will then ask specific questions so that I'm sure that I have the full story, because I think parents get so nervous when the child has a fever that you really have to speak to them in very short, direct questions. You also want to ask about the child's behavior, and you want to ask specific questions, such as, what has the child been doing today? What is the child doing right now? This is if you're on the phone. Has the child played at all today? Have you seen the child smile today? Is he interacting with you or with the other parent? You want to get very specific questions from the parent who's calling you or who's telling you about the illness, so that you can get an idea of how this child has been feeling at home. You want to ask about exposures or foreign travel. And with that, you might ask, is the child in daycare or in school? And has anything been reported to be going around wherever they are? You want to know their vaccination status. If you have their vaccine record available to you, you want to review that and note the dates that the vaccines were given, because sometimes if the vaccine was just given 1 to 2 days prior, the fever could be the result of the vaccination. You want to know if the child has any chronic conditions, because evaluating a child with a fever who also has chronic illness puts that child into a different category of risk. You want to know, in addition to antipyretics given, if the child is on any current medications. And you want to know what their fluid intake and urine output is, because with fever, there is an increased risk for dehydration. The fever makes the child uncomfortable and they refuse to drink. And in addition, it increases the insensible fluid losses and leads to dehydration. So you want to know what their urine output is and how it compares to their normal. So fever is considered a temperature of 100.4 or higher. There are two situations of particular challenge in neonates, infants, and children, and that's fever without any signs or symptoms of a focal infection. The concern is that the provider does not want to miss a serious but potentially hidden occult bacterial infection. So when we can't find the source for the fever on our history or physical exam, we need to start thinking and evaluate whether the child has any signs or symptoms or needs to be worked up for an occult bacterial infection. In infants less than 3 months old, the cause is usually viral, but in the first 3 months of life, we still need to evaluate the child for a potential bacterial cause for their fever. It's important for us to remember that viruses do have seasonal patterns, and that bacteremia, the prevalence of bacteremia in infants less than 3 months old is only 5%. It has come down since we started administering the Hib and the pneumococcal vaccines, which used to be the prime pathogens in pediatric bacteremia. But there are still other infectious organisms that can lead to bacteremia. Bacteremia may be occult in young infants and children, meaning it may not be obvious. And occult bacteremia is less than 0.5% of those who have been vaccinated with Hib and strep pneumoniae. So in the office, febrile children always demand careful evaluation and observation. Assess vital signs. Obtain a pulse ox reading if there are any respiratory issues. Do a complete physical examination, including a neurologic exam. Pay particular attention to the child's degree of toxicity and hydration status. And this box from your textbook has indicators for assessing severity of illness in pediatric patients with a scoring guide. This will be very useful for new clinicians because experience is definitely helpful in being able to determine the severity of illness in a pediatric patient. So for a novice practitioner, it's important for you to have as many tools and guidelines as possible to help you evaluate the severity of illness in your patients. This would be a good guide for you to keep handy at all times. Note that it includes level of consciousness, and the type of consciousness or quality of cry is rated as normal, moderately impaired, or significantly impaired. Hydration is always assessed. Color, respiratory status, reaction to stimulation by the parent or healthcare provider, and how they respond. Sleep to wake or wake to sleep state. Response to social cues. These are important indicators, and you should take these and use these in your assessment of the child. In fever without a focus, a diagnostic workup is usually begun. In a toxic appearing child, a child that presented with moderate or severely impaired signs, they would be admitted to the hospital even if they were 3 years old. A toxic child indicates infection, serious illness, and needs to be evaluated in the hospital. Once you've done your diagnostic workup, what constitutes negative workup or low risk? If the white blood cell count on the CBC is less than 15,000, usually we say between 5 and 15,000, it's reassuring. A cath UA should have less than 10 WBCs per high-powered field and should not have leukocyte esterase or nitrates. There should be less than 5 WBCs in a stool sample and a negative chest x-ray. That workup would be considered low risk. In that case, if cultures were obtained, the child could be sent home with close monitoring and evaluation where the cultures would be checked daily until they had no growth. Depending on the season and what type of viruses are going around at the time, there may be viral testing. For example, you may want to do an influenza rapid or an RSV test. And in febrile infants between the ages of 3 and 36 months, you'd want to consider obtaining a urinalysis and urine catheter and urine culture in males less than 6 months of age and in females less than 2 years of age, because urinary tract infection is the most common bacterial infection in febrile children that age. So this is your algorithm for evaluating and working up a child with a fever. And this algorithm comes from data obtained from numerous guidelines produced for evaluating the young child with a fever. So this is, again, a good tool to keep handy with you when you're beginning your practice, so that you can refer to it when you are examining children who are febrile. And again, the criteria to use this algorithm means that the fever has to be greater than or equal to 100.4 or documented by history. No serious underlying condition, including prematurity, and less than 8 weeks post-discharge. Heme oncology or congenital heart disease, severe congenital abnormalities, or prenatal complications. Any child that had any of those conditions, this algorithm would not apply to them. In addition, you wouldn't use this algorithm if the child appeared toxic, had chronic illness, or was unimmunized. So this is for a non-toxic appearing, previously well immunized child with a fever of greater than or equal to 100.4 that does not have any of these other conditions. You begin with the physical exam. If a source of fever has been identified by the physical exam, such as acute otitis media, or evidence of a skin or soft tissue or bone infection, and the child is under 3 months of age, you continue with the algorithm. If the source of the fever is not identified by physical exam, then you proceed to these 4 different options based on age. So if the child is 0 to 4 weeks of age and the source of the fever has not been identified by physical exam, the child will need to go to the hospital for complete sepsis evaluation and admission. If the child is 1 to 3 months of age, then a CBC with differential, possible inflammatory markers obtained, a urine analysis via catheterization for UAN culture is done. In addition, if there's diarrhea, you would consider a stool culture. If there were respiratory symptoms, you would do a chest x-ray. And the LP, if the child needed an LP, I would consider that child needs to go to the hospital. So you would begin the diagnostic workup in the office, and if there were any positive findings, including pneumonia, pyelo, elevated white blood cell count, then you would you could send to the ER for further study or evaluation. Or if the child was well appearing, you could consider administering IM ceftriaxone in the office with a 24-hour follow-up. But again, you would have a low threshold for sending that child to the emergency room for a workup. In the 3 to 6 months of age group, things get a little more relaxed. You're concerned the fever would need to be a little bit higher for you to need to use this algorithm, and you would follow through with the algorithm as it is there. And we can talk about this more in class, but this is a good guideline to use. So when you are seeing a child who has a fever with no focus on physical exam, then your differential diagnosis is going to include either an upper or lower respiratory tract infection, a gastrointestinal infection, a musculoskeletal infection, or a genitourinary infection, or occult bacteremia. And you're going to apply the risk criteria based on your clinical assessment and your laboratory findings. So a high-risk infant who presents with fever without a focus is going to be an infant less than 1 month old. And so any infant less than 1 month old with a fever is a high-risk patient. In addition, any toxic appearing newborn infant or child is high risk. If a child is toxic appearing, they are high risk. An infant of 1 to 3 months with a fever is considered high risk. An infant of 1 to 3 months with a chronic illness or unreliable caretakers is considered high risk. An infant less than 3 months, even with a focal sign, is considered high risk. Infants, children 3 to 36 months of age with a temperature greater than 39 degrees and high-risk laboratory results is considered high-risk patient. And child of any age who has fever, petechiae, and who is ill-appearing is high risk. In the child who presents with fever without focus, low risk is considered if the child is 1 to 3 months old, non-toxic appearing, and has low risk diagnostic results. 3 to 6 months with a fever less than 39 degrees and not ill appearing. 3 to 36 months with a fever greater than 39 degrees but not ill appearing, previously healthy, has focal signs, and has a positive influenza A. And 3 to 36 months, mildly ill, fever greater than 39, low risk diagnostic results, documented immunizations to Hib and strep pneumoniae. Again, following up for the child who is not hospitalized, who has a fever without focus, they would be evaluated within 24 hours, and you would need to ensure that they had access and transportation to an emergency department should they need it before their follow-up visit. You would do daily follow-up on any cultures that were obtained. You would see the child again immediately if the cultures were positive. And you would give detailed instructions to the parent on symptoms of worsening, what to do, and careful follow-up. So that's the end of the discussion on the child presenting with acute fever. We will discuss this more in class. Another condition of the child presenting with a fever is the fever of unknown origin, which is different than evaluating an acute fever without a source. A fever of unknown origin is a specific diagnosis that is given when the child has a fever present for most days of the week for greater than or equal to 3 weeks. This is a child that has been worked up for this fever and has had no identifying etiology for the fever. An infectious disease consult is recommended at this time. A fever of unknown origin may be a presentation of an infection, a rheumatological or connective tissue disorder, or a neoplastic condition. In children, the most common finding is a UTI or pyelonephritis, respiratory illness, or localized infections. However, it would be unusual to have not picked this up in the workup that would have been done over a 3-week period. In adolescents, the most common causes for a fever of unknown origin would be TB, inflammatory bowel disease, autoimmune disorders, or lymphoma. In managing fever, so in addition to working up the child for illness, regardless of the outcome, we want to make sure that parents understand how to manage fever in children. Hydration is an important aspect to the management of fever. Again, reviewing that fever makes children drink less and it increases their insensible or unmeasurable fluid losses. So fever is a risk factor for dehydration. Children can die from dehydration. So we always want to make sure we have a very good assessment and reassuring signs of their hydration status. We want to make sure that we reassure parents that the fever is a normal response to an infection, that it's not dangerous, and that it's helping them fight their infection. We want to make sure parents know how to clothe their child appropriately when they have a fever, that they do not make the ambient temperature too warm for the child, and that if the child's fever is above 104, they should consider a tepid bath in addition to antipyretics. Pharmacological management of fever, we recommend either acetaminophen at a dose of 10 to 15 milligrams per kilogram per dose, repeated every 4 to 6 hours as needed. An alternative treatment for children greater than 6 months of age is ibuprofen at a dose of either 5 to 10 milligrams per kilogram per dose every 6 to 8 hours. There is no indication to recommend alternating acetaminophen and ibuprofen for fever. It increases parents' anxiety and around the fact that fever could be dangerous, and it increases the risk for overdosing and inappropriate dosing. So we recommend parents choose one or the other, reminding parents that we treat fever mainly for comfort and for hydration purposes. We should be aware of a concept known as fever phobia. This is where parents become extremely fearful about fever, and their anxiety level is very high, and they don't understand that fever is normal, and they think that because their child has a fever, they should automatically be put on antibiotics. There is several citations in the literature regarding this fever phobia phenomenon, and we do have a responsibility to reassure parents about fever and try to explain to them in simple terms, layman's terms, what the fever actually is doing, that fevers less than 106 degrees do not cause brain damage, and that they can easily treat fever with either acetaminophen or ibuprofen, and they should not use naproxen as a fever reducer. We can talk more about evaluation of the child with a fever in class if you have any questions or concerns. That's the end of this presentation.